let's just, end the kind of wishful thinking thing that, oh, everything's great. I'm here to
because it's
testify it ain't.
universal. Because of that notion of universal. And I mean, that was the zeitgeist, I guess, of my nursing school experience was, aren't we blessed to have universal health care? And in theory, sounds like a fabulous idea. Of course, you want universal health care if that you have the capacity to do so. But I'm not sure that we really have it. I think we're saying that we have it.
Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC. And my big idea is to bring together people for conversations to brainstorm how we can improve the delivery of that healthcare in our region, make things actually better for people. And today the concept that I had was, let's pull back the curtain on what's going on in the emergency room. Maybe folks could really learn from how the grinding of the gears in the emergency room is going on so that they can know what to expect. So, with that, I've asked a member of the public, and a member of the public, I mean, hey, not an interior health employee, and not like myself, an independent service contractor for interior health, because that's what the physicians in this game are known as. And my member of the public is very near and dear to me. She's a podcaster in her own right. She's got a homeschool mama self-care podcast, and she works as a life coach for homeschool women. And with that, I'd like to introduce you to my wife, Teresa. Hey, Teresa.
Hey, long time no see.
Yeah, that's exactly right. And I'm grateful that you took the time to join with me, because the advantage that you're going to bring to this is to make sure that I don't get lost in the jargon or the weeds, because I do this every day of my life. It's my career. And sometimes if you start talking about computer programmers and how they got their code going, they can get into language that just isn't making sense to the average person out there in the general public. So thank you for providing that counterpoint, that balance. And let's kick this off by just saying, hey, when you stop to think about emergency care in our neck of the woods in BC, what kind of things come to mind these days? What's top of the thought process when you're like, hey, oh, maybe I've got to go to Emerge, or what's it like over there in Emerge?
Yeah. Okay. So first thoughts are that you're a lot busier. I can feel it since the pandemic, and I thought the pandemic was busy. So first of all, I think it's a lot busier. I'm hearing that from you and from other people that are also in that realm. I hear that locally, at least, or maybe across BC, we are having more of a healthcare crisis in that we don't have, especially smaller communities, don't have as much family medicine. They don't have, first line medical services. So people are tending to go to Emerge when they don't have access to healthcare.
Yeah, well, I totally understand where you're coming from on a couple of those points, because, like if we look at our statistics, once upon a time, and so by that I mean 6, 7 years ago, we would see maybe 40 patients in a day. That's over a 24-hour period. And
Mhm.
now we absolutely average 50, and many days are in the 60s and 70s. And yet we haven't really changed our physician complement. The same amount of coverage happens every day for physicians. We have 3 different shifts, they span the 24-hour zone. And we have upped our nursing complement to a factor of about 50% higher. But, nighttime, still often just 2 or 3 nurses. Daytime, we'd have 4. And we still got to deal with a high acuity. There's a lot of sick people still coming in. And I actually have gotten the impression that since the pandemic, there's more sick people. And then on the flip of that, you pointed out how primary care providers are harder to get. People don't have them. And so sometimes I hear people roll through and they're like, oh man, I'm sorry, I'm here in Emerge, but can you do this for me? And I'm like, well, you don't need to be sorry. I think the system isn't working very good, and I'm sorry for you. But yeah, you waited a while and now here you are. So we're not set up to provide that kind of primary care kind of notion, but we can do something for people. And so we do our best.
So what would you say the difference is if you go into a family doctor's practice, or for me, I'm on telehealth with my physician? What would you say the difference is between family practice and emerge?
Yeah, I think that's important. I think the more we can spell that out for people, maybe the easier it is for people to grasp why the experience is so different. So, perfect world, you have a 9 o'clock in the morning appointment with your family practice provider. And all things being equal, maybe they're 5 minutes late, but then you get your 10 or 15-minute appointment and you have your needs met. And they already knew you. They already had an experience of you. They're like, oh, here comes Jim again. And yeah, I know what Jim's like. And yet in Emerge, except for a few select people who are what we call our very frequent customers, I've never met you before. I have to take the default position that you're crazy sick. That even if you don't know you're crazy sick, I have to think that you're crazy sick, because otherwise I maybe am not like factoring some of those features in. And you've got to go through 3 layers to get to me. So like, what do you got to go through? You got to go through the registration or admin clerk. You've got to get through the triage desk. So that's staffed by a nurse, and they need to know what your severity, your trouble score is. We might come back to a little bit about how we triage score people. And then you're going to deal with your own nurse that you're assigned to in the department zone that you got into. And then I'm going to roll in. So that's a lot of kind of steps in the first place. And we're all actually a little bit worried that you're really, really, really sick. Maybe you
Right.
are.
Yeah,
Maybe
the
you're horrible
framing is
sick.
different. Mhm.
Yeah. And so then that just makes us come at you from a different point of view. And sometimes people are like, oh, why are you thinking all that? And yet it's inevitable. It's kind of what we're trained to do. And certainly if we acted in a kind of indifferent point of view, like, oh, I don't know why you're here, I guess we'll have to do nothing, nobody would find that very satisfying, because they'd be like, well, I was worried and I was sick, and why doesn't the doctor care? So, I think it's healthy that we're worried, but then it drags things out. Then the visits take a long time. Your experience is actually going to roll into many hours. It's a natural complaint people have. Um, I don't know what you've heard in the community in terms of like wait times, but it's become a big issue.
Okay, so I can remember that there was a 7-hour wait time at some point in Emerge. Do you remember that?
Do you mean in Nelson Kootenai Lake
Yeah.
Hospital kind of Emerge? Yeah. I've seen 6 hours on busy holiday
Whoa.
weekends quite frequently. So
Yeah.
yeah.
So what I hear you saying is that there's a different framing for family healthcare, family medicine versus emerge medicine. And you're assuming the worst almost, or you're maybe not the worst, but you're trying to rule out a variety of things. Where in family health or family medicine experience, someone already knows you, they know your history, they know all the backstories, they get a sense of who you are, what you're about, and you have nothing. So then you're coming in or coming at the conversation or whatever health challenge from nothing. And then you have to rule out the more complicated issues or the more challenging things.
We're trained to have them at the top of our mind, and then by a process of elimination to work
Mhm.
down.
Yeah.
Like, for example, if you come in with chest pain, well, chest pain's a very broad category. It could mean a lot of things, but there's 7 key things that if you have any of those 7, I have to deal with it now, and I cannot let you pass go or be discharged from the hospital if I don't figure it out, because they're life threatening. And so each and every patient who says, well, I have chest pain, by the process of history and physical and then investigations, whether that's lab work or EKGs or imaging, I got to get down to be able to rule out those things and then zero in on what might be your individual problem.
So it was something that when we were having conversation about having this conversation, we were talking about CTAS levels. And I've heard you use that a lot. And despite having a nursing background before we home educated our 4 kids, I definitely have heard you speak to CTAS levels over the years. but in a family medical clinic, you don't think in CTAS levels. Is that right?
Correct. Because, so in Canada, because this CTAS that you speak of is the Canadian Triage and Acuity Scale, it's a way to assess early on the likelihood of severity or trouble in a case, and then the timeliness with which someone needs to be seen.
Yeah.
So, like, for example, I kind of like playing cards and I like nicknames. If you're a CTAS 1, so I'm holding up the ace of spades, well, the nickname for the ace of spades is the death card. If you're a CTAS 1, you are either dead or about to be dead. And I'm supposed to drop everything else I'm doing
All
and
right.
attend to you. And, if you're the 2 of spades, well, I'm supposed to get to you pretty fast, but maybe I've got 15 minutes to kind of coordinate some stuff. And it's that kind of designation that then is a perfect explanation for why I can't run appointments out of Emerge. Because what if you're there because you think you broke your ankle? Well, that's a problem. Maybe you can't walk. You need an x-ray. You need help. Maybe you need a referral to an orthopedic doctor. Those are all reasonable and absolutely necessary things for you to show up at an Emerge. Where else are you going to go? But if a CTAS 1 and a CTAS 2 kind of case come in while you're there, I actually have to drop you like a hot potato and go see those and get on those cases. And then that can drag out your care for a while, because if there's a lot of sick people rolling through, your visit for an ankle injury is going to start tracking the entire afternoon. And, that can be pretty frustrating for people. So it's why, with our current system setup, we just don't have the flexibility and resiliency that sometimes people would like us to have. The ability to just kind of provide quick service care. It's not as easy. Whereas, when you're making an appointment out of the office, well, you're valuable, but we're not assuming that you're in imminent danger or you have a big problem hovering right over you. So,
Okay. Um, so what are the reasons that you think the emerge across BC at least, why there is more of a healthcare crisis now, especially after the pandemic? Because I've heard a lot of reasons and some of them don't compute for me. I'm curious what you think.
wow, yeah, multifaceted. I'll hit you with the top 3 or 4 ideas, and then we can kind of sift them around. So, item number 1 is we were busy enough for the infrastructure that we had back 5, 6 years ago. There was not a ton of extra flexibility. Item number 2, in a lot of centers, and they're the size of, for example, Kamloops or at times Trail, even our facility, we end up with admitted patients in our Emerge. So our Emerge is designed for 5 or 6 not life-threatening things, for 1 or 2 might be life-threatening things. These are bed spaces I'm talking about. And then for maybe 6 people who are being worked up for significant and serious problems. But as soon as we then have 4 admitted patients in those beds, well, we just lost half our capacity. And that happens a lot. So we don't have the infrastructure in our inpatient wards. That spills over into Emerge. That means it's harder for you to get a space to get assessed in Emerge for your fresh and new problem, your fresh and new abdominal pain or issue that has just cropped up for you. And then, seriously, I think since the pandemic, there is just a higher level of acuity. There's more sickness out there. I mean, our population writ large is older, and our amount of issues, some that were kind of suppressed for a year or 2, are kind of coming to the forefront, and there's more of them. And Mamma Mia, there actually isn't more people who want to work in this zone. We're having ER shuts downs in Oliver, in Merritt, in Lillooet. We've avoided that in the southeastern BC neighborhood for the most part, but we're part of the same health authority as some of these other places like Williams Lake, and there's kind of a knock-on effect. There's only so many care providers to go around, and some places just don't have what they need right now.
Yeah, I actually remember back in 99 when I graduated from my Bachelor of Science in nursing. And I remember writing a paper about the healthcare shortage that was impending. And it was 2013. They were anticipating 2013 having a significant crisis as we're seeing now. So that would have been like 7, 8, which how many years? A few years ago.
More than
And
10.
calculating on a live podcast. That's unwise always. But I remember thinking, oh, 2013, everything was it was busy, but it was okay. And then the pandemic, like right before the pandemic, I remember you just like, okay, I need to bring things back and do less. It was pretty intense, pretty saturated. But now it feels like there is a crisis that the regular people are noticing because they don't have their health care. They don't have their family doctors, and then they know that they have to go to Emerge and wait and wait and wait for what seems like, but why isn't the healthcare system equipped with the basics for me to just go get an appointment or get a prescription for something that I know I don't need Emerge for? So I see the crisis having, maybe it was 2013, maybe that's what they thought it would be, but now 2025 almost, and now we're definitely feeling it.
Yeah, it's like a slow unraveling. I think it's like we had a ball of yarn, but it's just slowly unwinding or unraveling, and the entropy of the situation is kind of having things fritter away. Because, like a real phenomena that from time to time occurs is people are stuck on waiting lists. Maybe they've
Yeah.
seen someone in an office, they got referred for procedure X or
Mm.
for test Y. Okay, that's fair. But now it's been another month or some span of time. Their quality of life hasn't returned. They're still suffering. And then, it's not uncommon for a kind of second opinion visit to Emerge. Like, oh man, how come I can't get my something? Like, can't I get it faster if I go through Emerge? And that puts a kind of a unique strain because you don't want to try to be a gatekeeper for people on that. And once they've appeared and you say, well, maybe it is an emergency, you've got to try and figure out some way of helping and address them. But that's a phenomena that now I see more than I saw 10 or 15 years ago. That people are there because they just need test Y. And they've heard that if they go through Emerge, they can get it on a more expedited basis. There's a kernel of truth to that. And then sometimes the magic is in navigating that space as a doctor to try and make sure that the right people are getting the right things in the right timing. And so, one more example of a knock-on effect, a domino falling over onto another domino, falling onto another domino. And I think we're at the place where most of the dominoes are lying on the ground. And unless we're willing to take a really deep dive, maybe big time system redesign, we're stuck playing kind of sliding down the hill, kind of losing game. That's my current opinion. So, I certainly, from my point of view, I want to be able to give the public hope. So my intent isn't to describe this as some kind of cynical, oh my gosh, this is a horrible thing. But, now, going back into sort of like what your perspective or opinion is, like, are you starting to form from a distance the perspective that things are just kind of really lousy and horrible? Or like, what do you hear when you talk to people out and about or that are in your sort of circles of influence?
Well, I mean, I come from the perspective that there's always hope, that we can change things or shift things. I think people have to be proactive in doing it and actually asserting their opinions on it. And of course, you and I have those conversations all the time. Um, I hear a lot, and this is just put a pin on that thought. I hear a lot from the American side that a lot of people would love to have a universal health care. And interesting, because I don't see that as universally beneficial. It might be benefiting some people at times, but it's giving a very generic healthcare plan to a bunch of people, and then you can get on wait lists to get the specialty stuff. So I don't see that as a really profound and useful approach to healthcare. Um, so I look at it and I say, yeah, I think there's an entire systems shift that has to happen. think it's not hopeless. I just think something has to change, and people actually need to, from, from the healthcare. Uh, I'm thinking from the administrative element, it needs to be less focused on maintaining status quo and actually shifting things in such a way that will make things function. How to actually do that, I know that it's multifaceted. I know that I couldn't even possibly speak to that fully. And I'm sure that there is not one person that is working in the system that could speak to that fully. But from my perspective, when I was in my nursing program, I was gearing up to move into the nurse practitioner role. And I remember that as a discussion point of we should be enabling more nurse practitioners to do more frontline healthcare. And then that will take the pressure off of the other people. And yet I also understand that that will change the dynamics of more intensity, I suppose, in the emerge or in various disciplines in medicine. So what do you think?
So to that narrow point, we do in our broad community have more nurse practitioners than we did 5 years ago. I think off the top of my head, I can count five, and I'd be happy to go deep and make sure that I had the right details on that. They are starting to assume some portion of the primary care provision. And then in a unique kind of twist, occasionally nurse practitioners' level of comfort with a certain cohort of patients is actually lower, and that just has to do with like the nature of the training and whatnot, and then those people get consulted or referred to emerge for a level of help. But I loved the part where you said we can't just keep trying to maintain the status quo, because I really observationally have seen that a lot of what maybe the last 10 to 15 years has been in Canada is how much more money do we need to fund this or pay this group of people so that we can kind of keep the status quo. And there's a political dynamic amongst that. That keeps politicians or parties in power or ministers of health going because, okay, all right, I've just maintained the status quo. Except this is where the kind of ball of yarn is unraveling. It's not workable anymore.
Yeah.
not from my point of view. And we're just like the canary that goes into the coal mine first. The part where people have heard that there's 12 and 13-hour waits to go to an emerge in Victoria is just kind of like the biggest news item, when really, there's 1 year waits to see an obstetrician, and pathology reports take way longer than they should, and you can't get a CT scan as an outpatient in any meaningful time in the lower Vancouver Island. Well, some of that definitely plays in our region in the Kootenay boundary and the East Kootenays. They're not as bad as some of those statistics, but it's trouble, and the population's not shrinking. In fact, our population has gone up. Our catchment areas continue to get older.
Yeah.
Older people. I'm living
Yeah.
this. Older people have more medical care needs.
Yeah, that's actually the other thing that I was thinking before is listening to another emergency physician speak about the population growing older. And that's what I remember being told way back in the day is, I mean, everybody knows that there's more healthcare issues when you get older typically, but our entire population is getting significantly older. So that is another reason for a greater demand on the healthcare system.
Yeah. And we can do things. Back in the day in the 1980s, when the Canada Health Act was introduced, a big sweeping legislation helped create standards for the way we were going to practice health and deliver it nationwide. What we do today wasn't at all heard of back then. The kind of diagnostics, the kind of level of investigation and workup that we can do for certain conditions now just wasn't a thing. Even when I was practicing in the emergency room settings in Alberta in the 2000s, I worked without a CT scanner in the community that I worked in. Not that dissimilar in size to Nelson. And
Yeah.
now there's so many things that might come through the doors when the standard of care is that I must get a CT scan for this presentation. So that adds
Yeah.
time, cost, expense. It's delightful because it gives a certain certainty and helps us get to conclusions with a better degree of accuracy for many conditions. And yet we're just including so many more things in our
Yeah.
recipes and for care provision that weren't experienced back when our system was designed. And I don't think we've had a meaningful, real big upgrade in our systems since back, in that last half of the 20th century.
So, what would you say are some of the solutions? What do you see as a true revamp?
Yep. Wow. We might need
Another
a
hour?
discussion to go deep into this. And thanks for tuning into this podcast. If you check out episode 1, I have riffed on some of this at a level that is going to exceed what I'm about to do. But here's the kicker. There's two things that I think for sure have to be added to how we think about principles of care. And one is that somehow we have to reestablish funding to follow a patient. Because right now, what happens is we create a program. So maybe we create an emergency department, or maybe we create a building or staff it full of doctors, nurses, and auxiliary care providers. And yet, just doing that doesn't ensure that anyone's actually receiving care, not in a timely fashion. They might just be sitting on a wait list.
Yes.
If the funding is attached to the patient, it incentivizes that program to find its own efficiencies, to
Right.
not accept stuff that will slow things down, to work around
Yeah,
it, get
that's
that
clever.
creative, innovative kind of approach.
Mhm.
And if I had no other kind of input that I could kind of like get active outside of the next 6 months or a year, it would be that kind of approach. And I have heard some politicians speak to it, and certainly it's something that I would be passionate about. I also
Can
think,
I unpack that in different words before you go on?
yeah, please.
Okay, so essentially you're saying that in behind the scenes, allotted to each individual will be a certain amount of money and that will follow them. And so the goal is to actually keep it within that budget per person.
Well, no, yeah, thank you for helping me clarify that. In fact, no, I don't mean that any one individual gets a budget. I simply mean that the Ministry of Health, because that is in our system the ultimate funder of how care gets provided, the Ministry of Health would send money to the Kootenay Lake Hospital when and if and only if I finished providing care to a patient for a certain procedure or a
Mm.
visit. Because right now, the Ministry of Health funds the Kootenay Lake Hospital Emerge to stay open, to have an infrastructure, and to have a certain staffing complement.
Okay.
And that will exist whether patients show up or not.
Mm.
And I want it to be that you get funded and it flows with the patient activity.
Mm.
Now, that may not apply to each and every item of healthcare provision, but it needs to apply to a lot of it because
Right.
that's how you keep innovation, incentive, and efficiency going in the system because that's what human nature thrives on. That's how we are making things better all over every part of our life, society, and
Mhm.
economy. Is someone is incentivized to be innovative to make
Mhm.
something better or to
Right.
find a more novel or more efficient way to do it. And I've heard people argue, oh, well, that just means you're going to do something American style. I'm like, come on. The Americans have enough problems. I don't need to copy anything they're doing. What it means is you're going to actually harness the power of human ingenuity and not let people kind of just be a little bit avoidant or, oh, well, I don't know if we can fit that one in. It's kind of late in the day. No, you need to be incentivized to keep providing care.
Yeah. Yeah. Interesting. Yeah, that is an interesting one.
Um,
Referencing episode 1.
yeah.
Yeah.
Well, one of the things that I was speaking to is that
Mhm.
I think we need to get out of some very fixed mindsets that we've seemingly adopted in the public discussion space around healthcare in Canada. And we just need to say, hey, how are they doing it in Australia? Hey, how
Yeah.
are they doing it in Scandinavia? And they're not doing it the exact same way we're doing it. And okay, no one country or no one system has a monopoly on the truth. But could we stop pretending for a moment that our system has a monopoly on the truth? Because it ain't going so good. Because, there's people employed and basic health needs are mostly being met, except for times when emergency department rooms are closed or stuff like that. Let's just, end the kind of wishful thinking thing that, oh, everything's great. I'm here to
Because it's
testify it ain't.
universal. Because of that notion of universal. And I mean, that was the zeitgeist, I guess, of my nursing school experience was, aren't we blessed to have universal health care? And in theory, sounds like a fabulous idea. Of course, you want universal health care if that you have the capacity to do so. But I'm not sure that we really have it. I think we're saying that we have it. And we're not. I think the benefit, I mean, there's so many potential reasons why moving to a different approach or trying to shift things a bit could have benefit to more people. Because just as you said, the use of CT 20 years ago is very different than what you use it now for. But we don't have the time or the space to accommodate for that. I also remember that in discussion of universal health care, that we thought we were covering everyone, but there's actually far reaches of Canada that do not have access to what we have. And what we have isn't accessed the same way as downtown Vancouver. And so it's not really universal. And also what I remember hearing the entire last decade or two and a half decades, is that the specialists, the special specialists will move to the States or somewhere where they're remunerated for what they're doing, and that there is a medical framework to receive them and utilize them. Whereas here, there there isn't as much incentive to be working in our part of the world because they're not remunerated as well. So then we're losing the specialists as well to places where they do get better remuneration. So you could say, well, we're all getting band-aids, but what if everybody doesn't just want band-aids? What if there are so many other potential resources we could use? And it just simply is not possible to fund every last technology or resource within a certain budget.
Yeah, I think the biggest thing I took out of some of what you were just saying is there actually is in our Canadian system this really big rural urban divide, and that
Yeah.
has a lot of real world kind of application issues in our region. So when we
Yeah.
think of like healthcare in southeastern BC, fundamentally we're rural and remote.
Yeah.
I mean, there's some lovely communities and there's lots of reasons to work and play here. But I got to tell you, I like living here. But if I ever develop a major vascular problem or a imminent neurosurgical emergency, I might as well just kind of get buried here because I won't be able to reach that kind of care in a timely fashion. And that's true across the spectrum for folks. So there's something to grapple with here in our discussion about emergency. Shall we say comprehensiveness? Are we truly comprehensive?
Yeah. Is it really
I
universal?
want an ability for everyone to access emergency room needs and issues on a universal basis. This is truth. This is a foundational pillar of how our system should be. But can we truly provide comprehensive care? Do we have the
Right.
mechanisms to move patients around or get them what they need at that higher level of specialty care? And a lot of what you were just speaking to absolutely are some of the biggest themes that we have to grapple with. But I don't really see that we're making progress on that.
Ooh, there's so many discussion points here. I think we could go into a lot more detail on these.
Yeah, and I'm grateful that you took time to spend at least a quick reveal behind the curtain of how we're sort of
Yes.
thinking about things or where things are at. Thanks, Teresa. I'm glad you came on today, and we look
Yeah.
forward to more discussions in the weeks and months ahead.
Yeah.